that Ian and I had about, I want to say a week or two, maybe 3 weeks ago. But it was a 4-year-old girl who came in, and she came in with a kind of like those typical symptoms of, like abdominal pain. Pain was kind of migrating throughout the abdomen. So on the left side at one point, on the right side on the other another time, kind of in the middle on other occasions. And the parents, mom was like great. She was kind of in tune with what was going on. Took her to, I think, the pediatrician at one time, and took her to another ER at another point. So this is kind of going over 2 weeks. Been having hard bowel movements, straining a little bit, and she's actually had a problem with constipation in the past. So history, but this particular episode at this time, she said, started about 3 days ago, worse with palpation, had some vomiting, no bowel movement today. And she was actually sent here from the outside hospital for an ultrasound. No x-rays or anything like that were done. I was just kind of like, all right, well, I'm concerned for Appy. We don't do Appies here, so we are going to send her to the UK. So with that said, what would you guys normally do for this patient? Just being completely honest, knowing that obviously we're doing this case for a different reason, but what would you normally do for these patients? Ashley?
I mean, she was sent from outside hospital for rollout Appy. I think you're kind of stuck. But if I saw her first, I might not have went down that road.
Given the history, what are you a little bit like? What is on your differential?
I mean, just constipation.
For sure, something.
And Molly, like, how would you normally, like, how would you work these patients up? Like, what is your typical protocol, I guess? I mean, it's not necessarily a protocol. Obviously, every patient is different, but how do you manage the patient, I guess?
It depends on the family. If I have a very low concern for anything being wrong, I'll do like an ultrasound or Appy. And
okay. Now, you get the ultrasound. Let's say the ultrasound says could not visualize the appendix.
Mm-hmm.
There's not really significant right lower quadrant tenderness, or there is a little bit of right lower quadrant tenderness, but most of the pain is the right end, just the lower abdomen in general.
I usually just do like shared decision making with parents about going home and coming back if it worsens. Talking about titrating Miralax or something like that to work with constipation.
Now, let's say you kind of hone in on this diagnosis of constipation. What would you like? How would you proceed? Like, all right, I'm going to stick with constipation. The ultrasound was equivocal. We want to kind of move forward with this. Like, get the patient home, get them in their bed. It's 11 o'clock at night. What do we do?
I think usually X-ray, AUB, or just plain pill.
Molly?
I do if I think of a family at once.
You do it if family. So it's not typically part of your protocol, right?
Right.
Is that what you're saying?
Right.
Yeah.
Okay. And Ashley, is it usually part of your protocol?
She has a really, really normal story for constipation.
Right.
I wouldn't say that I would have to do it, but if I did a KUB and there was like very little stool, then I would be more concerned, and I think I would probably admit her for acute abdominal or abdominal exams. So I wouldn't say with her story that I would have initially got a KUB. I probably would have just told them follow up with their PCP and done Miralax or trying to make her poop in the emergency department with an enema.
And what kind of typical enemas do you use?
Molasses enema.
I just asked the nurse
Molasses.
what the difference is. Okay.
So we actually ended up getting a KUB on this patient, or an abdominal X-ray on this kid. She was she was slightly pale appearing, and I'll tell you, when I walked in there, like she's like a cute, pleasant, and she's just sitting there watching TV. Mom doesn't really seem too concerned. We're kind of sitting there thinking, this is otherwise, right? I mean, looking at the kid's exam, belly felt like a tender, but kind of what you expect when you anticipate a kid that's constipated. And on top of all of that, like there wasn't any significant right lower quadrant tenderness. There wasn't, you kind of pushed in the lower abdomen in general and a little tender. But as you kind of migrated upwards, it got more tender. So our suspicion for appendicitis was fairly low. No fevers, a little nauseous, but no vomiting or anything like that. But the thing that kind of struck me a little bit for her was that when you looked at her and you looked at the rest of the family, she was like a little bit, her lips were a little bit more red compared to her skin. And then like how does she look like compared to normal? And they're like, she looks a little bit more pale. In that, I was like, all right, well, why don't we get some labs and a KUB just to make sure that it's nothing else? Because again, this is the abdomen, right? So we want to make sure that we're not missing anything. It's a 4-year-old girl. She's like right in that window for all those bad things, like the missed appy, the intussusception, the Meckles, and things that we don't want to miss,
The only thing I'd add to sometimes add on lactose strips even, or a finger stick if there's a history of diabetes.
Yeah, that's also a very, very good point, right? Because that ketosis can definitely, those ketone bodies in the body can definitely cause abdominal pain, that nausea, and this could be the presenting of DKA for her. So that's definitely a very, very good concern. Her blood sugar was, I believe, normal. So we kind of talked about this one, how we would go about doing this. So again, what we did was we got labs and we got X-ray and labs. Yeah. So this is the X-ray. What do you guys see?
It's weird looking.
So what about this X-ray is weird?
Well, so normally with stool, I mean, obviously it kind of looks normal down in the pelvis, like there's poop in the rectum, but then you look over in the right lower quadrant and there's like what looks to be like a huge mass or something.
Exactly.
Something that's normal.
Exactly. Right in that right side, right? That right lower quadrant.
Uh-huh.
If you look at it, it looks like the bowel is pushed up per quadrant, and then you have, it kind of looks like there's some sort of mass effect in the belly. You'd be surprised that you didn't actually feel it, because I went back there and I felt on her belly, and there wasn't really a significant thing that, hey, there's a mass here, like you should really look out for it. But you look at it again. When I first looked at it, I honed in on this right side, or this left side down here. I was like, oh, there's stool there, and the resident was like, all right, well, let's do an enema and get it out and get her home. But then I started looking at it a little bit more. I was like, it's an odd pattern. It's not a pattern that I've ever seen before, like the bowel being all the way up on that side. And to be honest, I didn't even really notice that giant mass in the middle, because I just kind of looked at it as, this is space tissue, adipose tissue, whatever, not like adipose tissue, but the general white appearance to the abdomen outside of the bowels. And then I looked at it and I was like, holy mass. So right around the same time, radiology called me and be like, hey, there's kind of like a mass there. You should either ultrasound or CT scan him. So we ended up doing both. The ultrasound was kind of non-specific, so we ended up doing a CT scan. It was pretty unremarkable. Potassium was a little bit high. Calcium and everything was normal. It's typically what you'd expect. You'd expect it to be a little bit higher, I guess, for a growing kid.
What did you tell the parents when you went in to their room?
So
sounded-
so this is one of those things, like you're telling the parents, all right, we're going to radiate your kid. We said we weren't going to radiate your kid earlier, but now we're going to radiate her, and they're obviously going to ask questions. So the way I approached this was, so just so you know, we want to make sure that we're ruling everything out, scare you as a family, but there is a concern that there might be a mass in her abdomen. Now, whether this is benign and obviously use better terms, like whether this is a serious issue or more of a benign pathology, is I don't have an answer for that. But I think the best thing that we can do right now, she looks okay, and let's kind of figure out exactly what's going on, and then let's bring you into the hospital so we can have our specialists, the people who know how to deal with this, take care of you properly. Whenever you tell a mother that her kid might have cancer, it's going to be, and I saw that when I told her, I saw sink, and she went a little pale. But at the same time, as long as you reassure them and tell them that, like, we can, and obviously don't give them any type of absolutes, be there for them, I think you're doing the right thing. This was one of the patient's rooms that I went into multiple times. Make sure that the kid was doing okay, make sure that her pain was controlled, make sure that the family knew that we're here for them. We're going to do the right thing for them, and like they can count on us. So that she's going to be okay and all that stuff, but you want to make sure that you at least give them as much reassurance and hope as possible. So kind of moving on, we got the labs, CBC, CMP were unremarkable. And then we ended up getting a CT scan. So this is what we were going through. So I kind of just went through the video of this. So coming up, you'll see that here's the giant mass right here, like a little blush there. So it looks like there may be some sort of blood supply or something there. So it was actually big, and you'd be surprised that you'd expect to be able to, but wasn't. Kind of move over to a case discussion. And the reason I wanted to talk about this, the reason case was important to me, is that this could have been something that was easily missed, right? How many times, I mean, what does the literature say about getting a KUB? And there's a recent thing on SGEM, which is completely appropriate, right? It's talking about constipation. It says that the abdominal X-ray doesn't add anything. Why doesn't it add anything to it, or read any literature on it?
Yeah, I mean, I have some, but
so basically what it says is that it doesn't add much, because constipation is a clinical diagnosis. So based off the Rome 3 criteria, which we'll go over in a little bit, you should be able to make the diagnosis clinically. The X-ray should not necessarily add anything to the diagnosis of constipation, because even after you eat like a large meal, you should be able to see like stool burden in your colon, because even though you're not constipated, you still have poop there, right? Like you ate something, you should have poop there. So your X-ray should show. That doesn't necessarily mean that you're constipated. And then on top of all of that, you're giving radiation to a kid for something that's not really helping you make the diagnosis. So that's the idea behind it, and that's why a lot of people argue, like, why are you getting an abdominal X-ray? So this is the Rome 3 criteria, and basically what it says is as long as you have 2 or more of the following, then you technically have a diagnosis of constipation clinically. The only thing is that it hasn't really been validated externally very much. It tends to be a little bit inaccurate in women. But I mean, it makes sense, right? These are the criteria that we use subconsciously. It's like you ask them, hey, have you been having any hard stool? Are you straining on the toilet? Maybe you don't ask them 25% of the time. We don't really ask them the caliber of the stool except for hard stools. And then the sensation of incomplete evacuation, I don't really ask those questions. But again, like things make intuitive sense to ask somebody whether they are to ask them whether to differentiate whether they're constipated or not, or if this is some sort of other etiology. Right? What kind of questions do you ask them?
How often?
Ashley?
I typically do you have hard stools? I feel is like the one thing I ask, and then how many times a week they go, or how frequent.
Yeah.
Yeah. If we're holding on to that stool and trying to wait till they get home.
Okay. Yeah. And the only other thing that I add to them is like, is there like significant straining? Like, do you sit like you have to sit there for a long period of time in order to have a bowel movement? I think the question ends up being, and the case kind of hinges on the KUB or not to get a KUB, or in this case, an abdominal X-ray. Opinion, if I wouldn't have gotten the KUB, and I'm not saying that I would have, because I was starting to kind of go into that. Don't do abdominal X-rays unless necessary. But if we wouldn't have gotten it, the question lies like, how long would this kid have been undiagnosed? How long would this mass have been sitting in her abdomen until we got an answer, right? I mean, how many times, like, she'd already been dealing with it for 2 weeks, and then finally came into our emergency department. If we wouldn't have gotten an X-ray and would have sent her home, would this have been another month and a half before she got an X-ray to have it evaluated? So are we basically delaying her treatment or delaying her diagnosis? It would have been my question. So what is thought process behind not kind of the stuff that we talked about is diagnosis. It can lead to misdiagnosis as well. So that's really important. So maybe it's an appy and we see the stool burden, we give them an enema, a little bit better, and we're like, all right, go home. And then the patient comes in with a perforated appendicitis. So that's kind of why we don't want to miss that. But in my opinion, if you're going to talk about this, I think that you have to bring up maybe I'm not necessarily just looking for constipation. Maybe I'm getting the abdominal X-ray for something else. Now, I'm not going to say that I was getting it for something else, because my suspicion was constipation and I got it for constipation. But sometimes it finds other things, right? Like, or a small bowel obstruction, or in this case, something weird that prompts you to do further testing, right? Why?
But were you really getting it for constipation, or were you getting it to confirm your suspicion? Like, you know what I'm saying? Like,
well, I think in my, like, to be quite honest with myself, it was more of a abdominal X-ray, see what we find. But mainly I'm thinking like stool burden, because my initial reaction when I looked at the X-ray, I honed in on side and was like, oh, there's stool there. Let's give her an enema. So like, I didn't really look at the picture holistically. I honed in on what I was looking for. And these are the types of errors that we make, right? I honed in on that and I was like, all right, that is stool. Let's give an enema. Let's get her home. It wasn't until I kind of like sat back and just by chance left it up and then just like really started looking at it. And I was like, holy crap, like, why is that way up in the right upper quadrant, a giant white space on the left side? And then I realized, like, holy crap, there's something else going on here. So I think that if you're using it to diagnose constipation, then it is probably reasonable to exclude certain things in her exam, like for me, color and just the sheer of her abdomen. Then I think it's completely reasonable to get an abdominal X-ray setting of looking for something else, looking for something weird that might prompt you to do further testing. Because I think the ultimate thing is that we've moved so far away from wanting to radiate kids that we're irradiating them enough. And I don't mean like we should obviously radiate kids, but we're shying away from studies that may end up being helpful because we don't want to give them radiation. And I think the important thing is, like, let's talk about how much radiation that we get. So it's measured in millisieverts. The abdominal X-ray is 0.05 to 1.1 millisieverts per, and your background for a year is 3.6. So that's a tiny, tiny amount of radiation that you're giving somebody for a study that may or may not be helpful. Was helpful. So I don't necessarily think that that we should shy away from X-rays just because of a radiation exposure. If you think it's relevant, I think that it's due, and I think that is ultimately my take-home point for the little session, is that, you know, if you think that this kid needs an X-ray and you think it'll be helpful, I don't think that it is wrong to do it. And you should have a low threshold to do it, because, I mean, chest X-rays and abdominal X-rays are, like, let's say a kid comes in, been coughing, sounds like pneumonia, but also has upper respiratory symptoms. I don't think it's bad to do a chest X-ray if you think it'll be helpful. You know, if you think it'll help them diagnose pneumonia and get them on the right treatment, because missing these diagnoses are way worse than actually X-ray and abdominal X-ray itself. Do you guys have any input, any questions, or anything like that?
Is Nick Moore even on here?
I don't know. He ended up coming on or not.
Kidding.
Oh, he is. Did he just pop in?
No, he's been on for a while. I'm just giving him a hard
Okay.
time.
Okay. So what ended up happening with this girl is, Nick, did you hear most of it?
Yeah.
Okay.
Sorry.
So, so what ended up happening was that she got admitted to pediatrics, got a pediatric surgery consult, and then she had a biopsy done. And right now it's just a cystic structure, and it's been sent out for pathology. So
What was it
no.
growing?
What was it?
What was it growing off of? You said off of her ovary, or?
It was off her ovary, yeah, over in fallopian tube, yeah. So.
Sorry, I missed that first part.
All right, so that's the end of the case.